So welcome. And with that, I'm going to kick it off with our first speaker. Our first speaker today will be joining us via video. We've got two speakers for this first session. Our first speaker is Dr. Lynda Polgreen. Dr. Polgreen is a pediatric endocrinologist who earned her medical degree from Mount Sinai School of Medicine. Following the completion of her degree, she completed a pediatric residency and postdoctorate fellowship at the University of Minnesota. And currently, Dr. Polgreen serves as an investigator at Harbor UCLA Medical Center and is also an associate professor of pediatrics at the David Geffen School of Medicine, UCLA. She practices as a pediatric endocrinologist at Harbor UCLA and Children's Hospital of Orange County, where she contributes to a multidisciplinary MPS clinic. I know we've seen Dr. Polgreen myself. She's fantastic. We're happy to have her today to speak with our first session on bone health and growth in MPS. And with that, we'll turn it over to Dr. Polgreen's session.
Good afternoon. I apologize I can't be there in person today to give this talk, but I will be there at the meeting tomorrow. So if you have any questions, please come find me and I'm happy to talk about them. I'm going to be talking about bone health and growth in MPS. Here are my disclosures. We'll go over bone health and osteoporosis and then talk a bit about growth. First, bone health and osteoporosis. So as I'm sure many of you know, osteoporosis is a problem that results in weak, brittle bones and ultimately an increased risk for fracture. These fractures are most common in the hip and the spine. There's a lot of risk factors, but most relevant for this population would be older age, immobility, inflammation, and hormone deficiencies. Osteoporosis is diagnosed using a machine called a DEXA machine, which is shown over here in the bottom right. And in pediatrics, what we look at is the lumbar spine, which is the lower part of the spine, and then the total body. Osteoporosis is diagnosed based on the results in this machine that give you what's called a Z-score. And that Z-score takes the bone mineral density for the child's age and gender and compares it to other kids of that age and gender. And if the Z-score, which is what's reported out, is less than -2, that is what would qualify as osteoporosis. Now, there's a variety of medications that are available to treat osteoporosis and can result in a decreased risk of fracture and improvement in the bone mineral density. An important thing to be aware of for children is that DEXA, it interprets smaller bones, so kids who have short stature, as being less dense than those of kids who have a normal stature. So meaning that the Z-score that's reported out by the DEXA machine will be falsely low unless adjustments are made. And this can result in the false diagnosis of osteoporosis in kids who have short stature. This is shown here in this figure that we published a few years back on DEXA data from a group of kids with MPS 1, 2, and 6. And what I'm showing here is the bone mineral density Z-score. So again, that what is reported out by the DEXA to diagnose osteoporosis on the y-axis. And the data from healthy kids in light gray and kids with MPS in the darker gray. A normal bone mineral density or BMD score goes from -2 up to +2. And on the left are the whole body data, and on the right, the lumbar spine data. The first thing to point out would be the bone mineral density Z-score by age, which would be the result that you get from the DEXA machine without adjustments for the short stature. And you can see here that for healthy kids, the bone mineral density on average falls around a Z-score of 0. But for kids with MPS, without any adjustments, that Z-score looks lower than healthy kids. And on the right, we've got the lumbar spine. And again, the healthy kids are around 0 for the average. And for kids with MPS, looks to be lower. However, when we adjust the Z-score for short stature using a calculation that was published a few years back by Zema et al., this results in a normalization of the Z-scores so that the average Z-score in MPS now looks very similar to healthy kids, and the same for the lumbar spine on the right. And so I show these data just to really emphasize the point that this adjustment for short stature in kids who who have short stature needs to be made, or else the diagnosis of osteoporosis might be made in error, and medications started that really aren't necessary. And so overall, I would say my recommendation for clinical practice is to start medical therapy for osteoporosis when there's a fragility fracture. So that would be what we call a low impact fracture, or there's a persistent decline in this adjusted Z-score for short stature. But what can you do to keep your bones healthy and strong and to prevent osteoporosis? Well, there are a few areas, one being calcium intake. And calcium, there's a recommended daily allowance, or the RDA, which I have listed here, which ranges from 1,000 milligrams daily to 1,300 milligrams daily. And in 1 cup of milk, there's approximately 300 milligrams of calcium. And so for kids aged 4 to 8, this would be about 3 cups of milk a day. And for kids who are in their teenage years, it would be 4 cups of milk. And the reason it goes up during adolescence is just because during that rapid period of growth, there's a lot of bone that's being laid down and mineralized, and so more calcium is needed. Another important thing to be aware of is that vitamin D deficiency can also decrease your bone mineral density. And most of us think about getting vitamin D from the sun, but it can also come in different foods such as salmon and other fatty fish, or also just over-the-counter vitamin D supplements. Risk factors for vitamin D deficiency include lack of exposure of the skin to the sun. So this can be either through clothing, not going out in the sun, or with sunblock. Dark skin and obesity also decrease the skin's ability to make vitamin D. Another important area are weight-bearing activities. So immobility is actually a very serious and important risk factor for the development of osteoporosis, because when the bones don't feel the weight, the gravity on them, the weight of the muscles pulling on them, they start to get weaker and weaker. And so really trying to increase weight-bearing activities as much as possible is an important part of keeping bones healthy and strong. And now let's move on to growth. So as I'm sure many of you are aware of, short stature is common in MPS 1, 2, and 6. And the data shown here are from a 10-year observational study that we did a while back in kids and adolescents, where we looked at a variety of different outcomes, and one being height. What I show on the left are the height Z-scores. And again, what a Z-score means is taking that patient's height and comparing it to other kids of the same age and gender. And the normal range for the height Z-score by age is -2 to +2, and shown here in the green box. And what we can see is that over time, we've got age on the x-axis here. The height Z-score, so how severe the short stature is, decreases over time for MPS 1H, or Hurler syndrome, MPS 2, and MPS 6. In MPS 1A, which is the attenuated MPS 1, or Hurler-Shea and Shea syndromes, we don't see that same drop in height Z-score over time. And all of these kids had been treated with either hematopoietic stem cell transplant or enzyme replacement therapy. So this shows you how short stature is persisting despite these treatments. On the right, we look at the adult height, for those kids who had reached their adult height. And here we can see that for MPS 1H, or Hurler syndrome, and MPS 6, the average height is far below that of the 3rd percentile for otherwise healthy adult females and adult males. For MPS 1A, so attenuated or Hurler-Shea and Shea syndromes, and MPS 2, the average adult height that we found in the 10-year study was around 5 feet 4 inches, which is the 3rd percentile for an adult male. And there's likely many factors that contribute to the short stature and the persistence of this despite the current treatments. One of these important factors is inflammation. And so these data here show the levels of a few markers of inflammation in the same group that I showed you in the last slide. And what we found was that there are chronically high levels of inflammatory markers in the MPS participants compared to healthy controls. And inflammation is known in a variety of different diseases to contribute to short stature through promoting growth hormone resistance. Now, other important things in terms of growth would be for progression in kyphosis and scoliosis, which would contribute to the short stature, as well as genovalgum, growth plate abnormalities, and hormone insufficiencies. I'll go over a few of these hormone insufficiencies that we do see more commonly in MPS. One of these would be growth hormone deficiency. Now, growth hormone is secreted from the pituitary gland, and it goes to the liver to make something called IGF-1. And IGF-1 is the blood test that we use to screen for growth hormone deficiency. IGF-1 then goes to the bones and promotes bone growth. Some symptoms of growth hormone deficiency are poor growth, fatigue, muscle weakness, and we do see, as I mentioned, growth hormone resistance in MPS and other skeletal dysplasias related in part to the inflammation, but also just related to some abnormalities in the growth plate itself. Additional risk factors for growth hormone deficiency include radiation to the brain or total body, which is used in some of the preparatory regimens for hematopoietic stem cell transplant. Not as commonly anymore, but historically was. But also the medications used to prepare a patient for bone marrow transplant can result in a long-term increased risk of growth hormone deficiency. In the cohort of kids that we followed for 10 years, we found approximately 10 to 25% of the individuals with Hurler syndrome and Hunter syndromes had growth hormone deficiency. So something to be aware of and to think about screening for on a yearly basis in kids who are at risk. Thyroid hormone is another important hormone for growth, and thyroid hormone is made by the thyroid gland, which sits here at the base of the neck. It's controlled from the pituitary as well, which secretes a hormone called TSH that stimulates the thyroid gland to make its hormones. And so when we screen for growth hormone deficiency, we look at the levels of TSH and T4 in the blood. Symptoms of low thyroid hormone or hypothyroidism include fatigue, dry skin, hair loss, constipation, and poor growth. Risk factors for this also include radiation to the thyroid gland. So this would be part of total body radiation, which again isn't used as commonly anymore, but has historically been used with hematopoietic stem cell transplant. Also, there's another type of hypothyroidism is called autoimmune hypothyroidism. And what this means is the body's immune cells attack the thyroid gland and cause it to not be able to make thyroid hormones. And this increased risk tends to run in families who have other autoimmune diseases, such as rheumatoid arthritis or juvenile idiopathic arthritis, type 1 diabetes. There's a variety of autoimmune diseases, but when those are present in a family, that does increase the risk slightly of other individuals having autoimmune thyroid disease. And this is called Hashimoto's thyroiditis or Graves' disease. And this deficiency, so low thyroid hormone hypothyroidism, we found in about 10 to 25% of our participants with Hurler syndrome, Hunter syndrome, and Marito-Lamé syndrome. Now, what else can we do to help increase height since it does continue to decrease over time, or the short stature worsens, I should say, over time, despite enzyme replacement therapy or transplant? Well, one of the things that we looked at was growth hormone treatment. And the figures shown here show you the growth charts, the height Z-score again, of kids with MPS 1, 2, and 6. The colored areas, the pink and the blue, are kids who were treated with growth hormone over time, and the black are those who were not treated. And in general, what we find is that if a child is growth hormone deficient, so not making enough growth hormone, they do respond a bit to growth hormone treatment. And some of the kids without growth hormone deficiency might respond, but it's quite variable. And so you can see some of the growth charts here, the projections. You don't see much increase in the height Z-score with treatment compared to those untreated, but other kids did seem to respond and have either an improvement or a stabilization of their short stature. Now, another approach that is currently being tested by Dr. Paul Harmitz and Ellen Fung at University of California, San Francisco is Voxzogo. Voxzogo was a drug developed for the treatment of achondroplasia and recently approved for that. And there's reason to believe from some animal model data that it might improve growth in MPS as well. And so they have fully enrolled their trial, and we look forward to seeing the results of this over the next year. So the take-home points here would be to screen for pituitary hormone deficiencies once each year after bone marrow transplant or hematopoietic stem cell transplantation. So meaning in those patients who are at risk for those pituitary deficiencies. For bone health, ensure adequate calcium and vitamin D intake. I'd recommend keeping the vitamin D level between 30 to 50 nanograms per milliliter. And if an individual is no longer walking or has a history of bone marrow transplant or hematopoietic stem cell transplant, which I didn't show the data here in the interest of time, but those treatments do increase the risk for osteoporosis. These people should be evaluated, I think, with a DEXA scan. But it's important to remember to adjust the results of that DEXA scan for short stature if it's present. So we're not overdiagnosing osteoporosis and treating with medications when not necessary. Could consider medical treatment if there's a low impact fracture or persistently decreasing bone density after adjustment for short stature. And finally, I would just encourage everyone to seek out information on clinical trials, so new therapies that are being tested for growth and other problems that persist in MPS despite the current treatments on clinicaltrials.gov. So I'll finish by acknowledging the many collaborators who worked with my team on the study that I mentioned, the 10-year observational study, and the funding we received for that. And of course, a special thanks to the study participants and their families for participating and really making the study successful and possible. So thank you for listening. Here is my contact information. Again, I will be at the meeting tomorrow and I look forward to seeing everyone. And if you have any questions, please find me and we'll get those answered. Thank you.
Thank you to Dr. Polgreen for that. Yes, please feel free to seek her out tomorrow. She is a wealth of information and a great resource. So I encourage you to do that. Our next speaker I'm honored to introduce is Dr. Klane White. And Dr. White is the chair of the Department of Pediatrics, Orthopedics, and the Rose Brown Endowed Chair of Pediatric Orthopedic Surgery at Children's Hospital, Colorado. He is a professor of orthopedics and vice chair in the Department of Orthopedics at the University of Colorado School of Medicine, where he is also professor of genetics and metabolism in the Department of Pediatrics. Dr. White, renowned in his field, is an internationally recognized expert and advocate in the care of MPS and skeletal dysplasia. He serves on the board of the Medical Advisory Board of Little People of America, the Scientific Advisory Board of the National MPS Society, and is the principal investigator for multiple international research studies and on emerging treatments in rare disease. Dr. White's also an MPS parent as well and a dear friend. And with that, I'm happy to introduce Dr. White.
Thanks, Lisa, and thanks for not torturing us with that long bio that I submitted. So yeah, it's really always a pleasure to be here, especially on the 50th anniversary. And it made me do a lot of math in my head about when I started doing things and so forth. And we were about 25 years to the day when we learned of Susanna's diagnosis. It was clearly right before Christmas, and it was I was driving in my car, had two little girls in the back when the geneticist called me. It was not really the greatest way to learn about it, but anyway, that's where we are now. I have disclosures as well. I am involved with a lot of clinical trials and do consulting, but I don't think any of it has anything to do with what we're talking about today. And I will disclose that I am an orthopedic surgeon. I'm not a bone physiologist, biologist like Dr. Polgreen. She's much smarter than I am. I am a glorified carpenter. And as Lisa pointed out, this is my daughter, Susanna. She's with us for 9 years. She was diagnosed in 1999, so 25 years ago. So exactly half the time of the MPS Society being together. Hopefully video works here. Today, let's see, will it play? There we go. So really Dr. Polgreen talked about this a little bit, is the growth plate is at the ends of long bones. This is what is responsible for growth. And it's sort of our organ, pediatric orthopedics. And what happens is you have a layer of cartilage cells there that sit at the ends of the long bones, and then they replicate and extend. And so think about if you have, say, your femur, which is, this is the version of the femur, the ends grow away from the center of the bone. Now, in normal situations, then you get a nice long, relatively appropriately straight bone. But in MPS, what happens is this system gets disrupted. And so this results in a difference in the way the bones are shaped. In addition to that, joint cartilage, so the glistening surface of our joints, has shown sort of that white little stuff behind the kneecap there. That's also affected by the inflammation of the long bones, or by the inflammation from the MPS. And so we get a couple of different problems with MPS, which I'll talk about today. And this is just a cartoon saying you can see where MPS affects this growth problem here, which is in the proliferation of these cells. In the end, this is a constellation of problems in the bones and joints known as dysostosis multiplex, which really just means multiple bad bones. This is a radiology term. So oftentimes you'll see this in radiology reports. And this is skeletal disease. It affects all of the bones. It's very specific to MPS. And it's mediated by this accumulation of glycosaminoglycans. And we think of them as sort of, we call them, storage disease. And you have this accumulation and overstuffing of cells, but it's just not a physical thing. These are very biochemically active molecules. And so that's what affects the biology of the growth plate. So in young children, as I mentioned already, this results in deformity of the bones. And as our family or members or ourselves age with MPS, then you get degeneration of the joint cartilage as well. And that results in arthritis. So I'm going to talk today a little bit about what we can do to maybe better improve people's quality of life with orthopedic surgery or otherwise. And so when you're considering doing something about this, either it could be medical management, it could be surgical management. You always have to ask the question, is this intervention going to include function? Is it going to decrease pain? Or is it going to improve quality of life? And I think this checklist, which I pulled off of Google, is really great. Does it help? Will you sleep better? Will you be happier? Will help your overall mental health, daily living, job, social life, etc. So these are the kinds of questions you need to ask yourself and your physician when you're talking to them. Now, there are alternatives to surgery. So as a surgeon, we're supposed to go through this first if we do it the right way. We talk about weight loss, we talk about assistive devices, braces, and pain relieving medications, either non-steroidal anti-inflammatory medications like ibuprofen or Aleve, and I have no stock in either company, Tylenol, or steroid injections into the joint or otherwise. So when do we operate? Well, I think we have to have some pretty clear boundaries about this. So first of all, pain or deformity that affects everyday activities. Certainly pain at rest or at night that prevents sleeping. I'll talk a little bit about spine problems. So we talk with more severe spine deformities, you can get neurologic deficits. That's certainly a reason to intervene. And sometimes we just know it's not going to go well. But I'll talk specifically with hip surgery. I'll go over that to a certain extent. Now, this is not meant to be memorized. This is just a cue for me to show that there are many different parts of the skeleton that are affected. So I'll start at the neck and work our way down to the feet. And all MPS disorders have some element of bone disease. So I'll start at the neck. And so the one issue that we worry about probably the most because of the catastrophic nature, if it goes bad, is cervical instability. So at the base of the skull is our first cervical vertebra, or C1. The one below that is C2. Now, particularly in Morquio syndrome, but in other forms of MPS, those that live with some ligamentous laxity, those bones can move on each other. And so these are two rings that move on each other. And if you think about the hole that's formed from those two rings, if they move, then that hole becomes smaller. Well, what's in that hole? The spinal cord. So if you have instability at the base of the skull, then you can end up quadriplegic if this is unrecognized or untreated. The rings are also smaller, so there's even less room for error. And then we have accumulation of glycosaminoglycans around the spinal canal, So that even makes it even smaller. So you have a small space, and so even a little bit of instability is of greater magnitude than someone who doesn't have MPS. And this is just an example of what we see on imaging. So on the left, you have a CT scan. You can see that one ring, you're looking at the rings sort of on sides. You're kind of looking at circles. So that C1 is sitting forward on C2. And then if you look on the MRI on the right, there you see that little blush in the spinal cord where that arrow is. That's where this child fell and then pinched their spinal cord. And that's a bruising of the spinal cord. Luckily, this child who was quadriplegic transiently recovered, and we were able to stabilize him with surgery. So what should you be thinking about? Because this is a bit of a slow process sometimes. Myelopathy is the term that we use in medicine, but this is basically signs of spinal cord irritation, so weakness, clumsiness, bowel or bladder control issues. Sometimes if you have instability, you'll get neck pain, and so the muscles are working hard to keep that stable, and so you get neck and headaches. And so, as I mentioned, neurologic changes are probably the primary reason why we want to intervene. Sometimes if it just is a really small canal and we know there's some instability, then we will go ahead and intervene before that. So that would be more of a, we know a bad natural history. So that's when we would intervene. The most common finding in MPS that we see from a skeletal standpoint, at least maybe most pathognomonic anyway, is the kyphosis of the spine. And I will say this is how I've made probably the most of my, as an orthopedic surgeon, diagnoses. When someone comes in and sees me because they have a quote unquote bump on their back, and it's really just because their spine has a forward bend in it. And so this is a problem that generally doesn't need treatment right away. We can try and delay either with bracing or just observation. We know that certain curves tend to get worse if they're a little bit bigger. In the end, again, because the spine is bending forward, this can result in stretching the spinal cord and can result in problems that way if it's high enough in the spine. Sorry, and that's the. So this is the surgery. So this is an X-ray example of what that bump looks like. You can see that forward bend in the spine, which is then fixed with surgery. This is there's a lot of ways to do this. You just need to make sure that your surgeon gets the spine straight to avoid revision surgery, because if you don't get it straight the first time, there's a good likelihood you're going to be back. And usually I'll brace the kids for about 3 months afterwards, just because the bones are a little small and we don't want the implants to pull out. So that's that. And this is just an example of one of my kids who we got straight, and so, you know, I did this at age 5, a little younger than I like, but and nonetheless. Scoliosis is much less common. So this is probably a condition that we're much more accustomed to hearing about. This is a sideways curve in the spine. The difference between scoliosis and kyphosis is that scoliosis tends to squish the lungs, whereas kyphosis tends to stretch the spinal cord. So 2 different problems that you're worrying about. With that said, they often have a component of kyphosis or forward bend in the spine, so that makes them all that more challenging when we're trying to fix them. And so how do we fix them? Again, you can cast or brace. Growing rods are an option, although I've never put growing rods in the MPS kid. They just don't seem to occur early enough, because by about age 9, we're more likely to do a definitive fusion for scoliosis. And that's what's shown on this upper X-ray on the right. The growing rods are on the left. But you can expect, especially with growing rods, a lot of complications. So that's why we try to avoid it. Here's just another video of kind of what we do in spine surgery. We take bits of bone away so that we can loosen up the spine. We'll go ahead and put implants in. We put the rods in, connect them to those screws, and then we can use those rods to straighten the spine. Then we put bone graft in at the end. So this is what we call an instrumentation and fusion of the spine. You think about it as concrete and rebar. So you kind of really have to have both to hold that straight for the long run. I think everyone gets the idea, and I don't want to overdo my time here. So this is just an X-ray example. You can see it's a, I'm going to leave the pointer here. Oh, sorry, I'm going to look over here. Oh, sorry, I didn't need to do that. I'm going to point over here. There's that kyphosis there. I said, but here's the scoliosis and often the associated kyphosis. but you want to take care of both. And that, again, this is a definitive fusion with those rods and screws, and this is what it would look like radiographically. The hips are a little bit more tricky. There's two things going on here. One is deformity, and as I mentioned, sort of the biological aspects. That biological problem we call epiphyseal dysplasia. Sometimes you'll read on a report, it'll say osteonecrosis or avascular necrosis of the hips. But then we also have hip dislocation or subluxation. So subluxation is when the femur starts sliding out of the socket. Either way, both of these can result, if untreated, in early arthritis, and often as adolescents, sometimes as young adults. So this is the epiphyseal dysplasia. These are morchio hips. You can see that ball where those arrows are should be nice and round, but here it looks like it's completely dissolved. Perthes disease is another thing you'll hear about, but this isn't really Perthes disease, but it can look like Perthes disease. Again, this results in pain and early arthritis. This is just what hip dysplasia looks like. On the left is a normal X-ray, and on the right is a child with MPS 1. And you can see how the hips are not contained in the joint. And this is just what we kind of look at. This is called Shenton's line. You're looking at that break. So those lines should be overlapping. That just shows that the hip is sitting up and out. And this is contributed to by both having a high neck shaft angle and a dysplastic socket, resulting in subluxation of the hips. So if we treat this, there's a couple different ways, depends on where you go. If you go to DuPont, they're going to do what's called a shelf acetabuloplasty. I do a pelvic osteotomy. Either way, we're going to try and treat the femurs. This is what that looks like radiographically after those hips are well seated. And here's I just got another video here to kind of share with you. I think these videos really help give you an idea of what it is we do in surgery. So here, this is the femoral osteotomy. We're cutting it, we're kind of tipping it in so it points towards the joint. And then we'll secure that with plate and screws. And then we make a separate incision on the front of the hip, where then we cut the bone of the pelvis just above the hip joint. We sort of lever that down to deepen the socket. And then we put a piece of bone graft in there to hold that open. And now you can see that that hip is sitting in nice and deeply. So let's finish up and then I need to get these on 1.5. It's like my podcast. So this is just some data out of University of Minnesota that shows that we're still not totally sure how much the benefit of hip surgery is. I think it's beneficial for many reasons, in that it actually makes the anatomy a little easier to deal with if you need a hip replacement later. But as you can see here, if you looked at those who had surgery versus those who didn't, out of 100 kids, 3 ended up having sort of bad hips if they had surgery, and 2 who didn't have surgery had bad hips. So the outcomes are about the same. And if you look at the long-term outcomes from Ireland, you can see, if you look closely in here, it says advanced hip disease all down here. So, you know, even though we do hip surgery, they still end up with arthritis of the hips. And these hip scores are quite low. So in adolescents and young adults, we offer hip replacement surgery. This is very effective in MPS patients because most MPS patients aren't doing high demand activities. You know, if you're walking and working and sitting and, you know, kind of doing that kind of stuff, these hip replacements now will last for a very long time, which is why we always were hesitant to do them at young ages. But they are technically more complex, so you need to go to a center where they actually have experience with complex hip replacements. And they have to be aware, and I'll talk about this at the end, about the medical comorbidities that are associated with MPS. And so this is just the last video, I promise. And this is kind of what a hip replacement looks like. There's the arthritic joint. They'll remount the acetabulum. They'll put this metal socket in. It actually has a plastic liner on it. And then they will take off the head of the femur and put an implant there, and then that will join up together. And this is what a hip replacement looks like. So, and there's the arthritic femoral head. Yep. Okay. So moving down to the knees, knock knees or genu valgum is the most common problem we see in MPS. It usually presents about 3 to 4 years of age. and really can affect mobility. If you try and think about someone walking and they're constantly bonking their knees together, this has been shown with some good studies that if you can correct this, they actually have better mobility. And right now, the way we treat this is what's called guided growth, or with tension band plates. You may have heard of 8 plates. I lied, there is one more video. So this is where these are just little plates with screws, and all we're really doing is tethering the growth plate on one side so that the other side can grow and the legs can straighten with growth. And this is what the x-rays look like. Carpal tunnel syndrome, very common in MPS. This is just due to thickening of the tendons and the ligaments around the median nerve. And oftentimes children won't complain of pain, but they certainly can have decreased function in the long run. It also can be associated with trigger digits, specifically in Hurler syndrome. And so surgery to fix this is often required. And the last thing I'll talk about is tarsal tunnel syndrome. You know, the data on this is really scant. Plantar foot pain or tingling, nerve conduction studies aren't as reliable as they are with carpal tunnel syndrome. And you have to rule out spinal pathology, because if you have a spine problem, that can mimic foot symptoms. And so there is some literature on this, but I will say that it wasn't really overwhelming. And if you want to, I can go into the detail later on this. As an orthopedic surgeon, you know, I at least try to be cognizant of this, but not every orthopedic surgeon is. Airway and anesthetic management, if your child is going to have surgery, is critical. You need to make sure that you have adequate clearance from a cardiologist, a pulmonologist, and ENT before having surgery. You need to have a good airway person, an anesthesiologist who knows how to take care of children with MPS, and neuromonitoring for any cases that occurs for over an hour. So there are probably at this point over 24 MPS kids around the world who have had surgery for hip or lower extremity problems and woken up paralyzed and never walked again. So their lower extremity surgery is absolutely worthless at this point. And there's a lot of this information is on a website for a skeletal dysplasia group that I work with, and I encourage you to go where there's these free resources, PDFs. There's patient-friendly ones. There's also the actual papers, which you can download for free. So please go there. So learning points: spinal cord compression is common in MPS and ML and requires regular evaluation surveillance. Hip dysplasia is extremely common in MPS 1 and in Morchio, and should be treated when subluxation occurs at the very least. They can still develop biological problems and need hip replacement regardless of surgery. Knock knees are responsive to guided growth, and GAG accumulation can result in peripheral neuropathy such as carpal tunnel syndrome, tarsal tunnel syndrome, and always be diligent about perioperative care. So with that, I thank you, and finished a little over time.